At any one time in England, there are about 2,000 people with learning disabilities and/or autistic people in long-stay hospital settings, sometimes for many years with no sense of when they might get out. This is problematic for 4 reasons. 1. Hospitals are not geared up for helping people lead an ordinary life. 2. People are often a long way away from friends, family and communities. 3. It's extremely expensive, taking money away from stopping people getting admitted to hospital in the first place, or providing support for people in the community after hospital. 4. We have seen horrific abuse scandals, as raised by BBC Panorama and others, in highly pressured and sometimes remote hospital environments. Against this background, the University of Birmingham and the rights-based organisation Changing Our Lives have carried out a joint project in order to better understand the experiences of people with learning disabilities and/or autistic people in long-stay hospital settings. Encompassing the experiences of people in hospital, their families and frontline staff, the intention is to use this knowledge to create a good practice guide, as well as training materials, including this video, to support new understandings and new ways of working. The project was led at the University of Birmingham by Professor John Glasby.
We've been running a 2-year research project funded by the National Institute for Health and Care Research in 3 long-stay hospitals across the country. We've talked to 27 people with learning disabilities and/or autistic people who are currently in long-stay hospitals. We've also interviewed their families where they've given us permission. We've carried out focus groups with hospital staff, and then we've done some work with commissioners, with social workers, with advocates and with social care providers who often support people after hospital to get their perspectives. We've also reviewed people's case files and we've observed multidisciplinary decision making meetings. And then finally, we've tried to follow people up 12 months after their original interview to get a sense of what happened after we first met them and where they are now.
Contributing to the research was a reference group of people with learning disabilities, autistic people, some of whom had spent considerable periods of time in hospital, as well as their families. Many people with learning disabilities and/or autistic people have found themselves in and out of hospital on multiple occasions, sometimes since childhood. This was the case with reference group member Zizi, who was first admitted as a teenager and spent 4 years in secure settings.
I first got poorly with kind of self-harm and things when I was 11, but when I went to hospital that was from the ages of 14 to 18, and so I was in hospital for that amount of time. I was sectioned I think 4 times and had 5 admissions. I was in units all across the country, so I was in Staffordshire, I was in Sheffield, Wales even, and quite a few hospitals in Birmingham.
Levels of anxiety and distress experienced in hospital were intolerable for many of those contributing to the study. Reference group member Mandy, who had been in several hospitals in her 20s and 30s, shared her experiences.
The horrible bloodies put me in a room on my own all day. And I had to come out and watch the TV with you as patient. Lonely, scared, frustrated, didn't know what was happening to me. I don't like hospital, I don't want to back in none of them, I don't like them.
Although their experiences have too often been negative, many people included in the study understood why they had been admitted to hospital, as did reference group member Matthew, who spent approximately 16 years in secure hospital settings after the support he was given in early adulthood failed to meet his needs.
It's not nice having your freedom taken away, but if it's necessary, and so it has to be done to keep that person safe and people safe.
The research revealed that people stuck in hospital felt that they were not being listened to. Equally, family members consistently expressed the same concerns. Vivian Cooper, the Challenging Behaviour Foundation.
You have a system that is not taking notice of the person or the family or their advocates or people who know them well. And that's a missed opportunity because those people are able to articulate and say what needs to happen and what will help them.
One of the outputs of the research project is a good practice guide called Why Are We Stuck in Hospital?, aimed at overcoming the barriers faced by people with learning disabilities and/or autistic people as they leave long-stay hospital. John Glasby explains how the project outputs were created.
We've drawn particularly on people's lived experience and also on the practice knowledge of frontline staff, and we've drawn those up into 10 top tips to try and help more people come out of hospital in future. Those are based primarily on people's experience of being in hospital, the barriers that they faced and ways that they've tried to get round them. And we think that more bottom-up attempt to solve these policy and practice issues by listening to the voices of people in hospital, listening to their families and listening to staff is perhaps a better way or a richer way of trying to resolve these issues than some of the more top-down policy measures that we've taken in the past.
The tips, derived directly from the experiences of those in hospital, are intended to help all those involved in the process, from clinical staff to social workers to commissioners, to achieve better outcomes. Tip 1. Our lives are on hold. Do your jobs and get some oomph.
People have been in hospital for many, many years, and there's a real sense of their lives being on hold. What they want health and social care professionals to do is just to do their jobs, the basics of what they're there to do.
But it was a struggle. It took months. I think I was in that unit. I was only meant to be there for a really short term, like 1 or 2 months. But I ended up being in that unit for about 7 months just because it took so long to get me out.
We know that the average length of stay for a person with a learning disability or an autistic person in an assessment treatment unit is over 5.5 years. That's a huge amount of time, a massive chunk of people's lives when they could be living. So I think there needs to be a sense of urgency.
Anne-Marie Glasby, Changing Our Lives.
Some of the people that I met spoke about someone in their team. Sometimes it was someone within the clinical team in the hospital, and sometimes it was someone from an external agency, a social worker or a commissioner, perhaps that they had a good relationship with, who they felt were trying to move things forwards. But often that wasn't the case. Some people I met had multiple social workers in the time that they were in hospital, or they never saw their commissioner, they didn't know how to get in touch with people, and they just felt like there was no one really kind of taking charge, taking things by the scruff of the neck and moving things forward, really.
Tip 2. See the person behind the labels.
People with learning disabilities and autistic people have a lot of labels attached to them, and they find that the longer they're in the system, whether that's hospital or any kind of community-based system, very often they acquire additional labels.
Throughout most of my admissions, people were kind of saying, is this psychosis or is this personality disorder, or is this autism or is this personality disorder? And everybody was so hung up on getting those diagnoses right. They weren't looking at me as a person, what I needed.
There is meant to be a person-centred approach. We are meant to be starting with the person first. But typically, as this research has shown, is that the reality for people is that they're often seen according to their labels rather than the person that they are.
Tip 3. Don't make me jump through more hoops than is really needed.
Many of the people we've spoken to feel that they have to prove time and time again that they're ready to come out of hospital, that they have to comply with whatever they're asked to do, and they have to demonstrate that they're safe to come out. Sometimes that can involve, though, jumping through multiple hoops, and often more hoops than might strictly be necessary.
The things they had to do changed over time. So they thought that what they needed to do was one thing, complete a particular course of treatment, or perhaps like a talking course, a discussion group. And they thought that when they got to the end of that, that would mean the next thing would happen. But actually the goalposts changed, if you like, and they were given something else that they had to do.
Because the person isn't in the right environment, their behaviour can be quite challenging. And then the longer that you're in the environment, the more challenging it becomes. And then that means that you're not able to get out of hospital. So it's a vicious circle.
There were so many hoops to go through, like they had to go through all these different panels for funding. Once one panel said that they could agree the funding, then they had to go through another panel. You know, I wanted to go out, I wanted to do my A-levels, I wanted to go to university, I wanted to become a doctor, I wanted to do mental health campaigning, I wanted to speak at conferences, and I had to try and do that from being in an inpatient ward, and that was really difficult.
Tip 4. Make sure the criminal justice system is on board where someone has committed an offence.
Many of the people in our research had committed an offence or come out of the criminal justice system, and the decision making has to be joint between the health and social care system and criminal justice. However, we had a strong sense that it was health and social care who were working with the person day in and day out, and that the criminal justice system was very distant, yet was often the key decision maker.
Catherine Nolan, West Midlands ADAS.
Colleagues in the Ministry of Justice actually work from a different emphasis to those of us who support people with learning disabilities and autistic people in inpatient settings or in the community. And quite often, if you like, we come from, certainly for people with learning disabilities, an enablement, an empowerment, a right to take risks and make mistakes perspective.
So months could go by while information was going backwards and forwards between health and social care and criminal justice. And what sometimes felt to people like quite arbitrary decisions could be made a long way away from the person by somebody who didn't know them, who was responding to a report, not responding to the detail and the reality of the person's needs. So having a really close relationship between health, social care and criminal justice felt crucial if we were going to make decisions in a good way and in a quick way.
People spoke about their frustrations of applying for unescorted leave, and one person I think had applied 6 times for unescorted leave. The hospital, their clinical team, felt they were ready, and they'd applied to the Ministry of Justice 6 times and they'd been turned down each time. And every time that happened, it took a significant period of time. People said to us, they've never met anyone from the Ministry of Justice. They don't know me as a person. They're just reading reports about me and making a decision without meeting me. They don't come to my meetings. They don't know anything about me as a person. And so that was a really significant block for a lot of people.
Tip 5. Help hospital staff know what's available in the community.
Often we found situations where hospital staff were trying to decide what kind of service they thought would be best for the person after hospital. But it wasn't always clear what they were basing that decision on. Some people had always worked in a hospital setting or hadn't worked in the community for many, many years. So we felt that the hospital had a responsibility to learn more about what's actually available and what's possible in the community. And equally, the community had a responsibility to help hospitals understand what was out there for people.
There's still a bit of a mentality around which is where can we put this person, rather than what is it we need to put in place around this person to enable them to live successfully in the community.
So when I was ready for discharge and when I said I want to be discharged, the team didn't really know what was available in the community. Like I think community and inpatient are very separate and they work very separately. They don't work cohesively when they probably should.
Very often, the staff that I met wanted something different for the person. They wanted them to leave hospital and they wanted them to lead a life that they deserved in the community. But what they didn't always know was what was available and how that could be achieved. And it seemed to work best when a hospital had a good relationship with a provider in the local area.
Often what families tell us is that when they're considering what is available and what needs to be in place for their relative, they're given information about what's available, not what's possible. And so if what is needed isn't available, but it is possible to create it, often that's not given as an option or an opportunity.
Tip 6. Don't put us into boxes or scattergun.
I met a lot of people who had multiple, or told me they had multiple diagnoses. So perhaps they had a learning disability and they had a personality disorder, or they were autistic and they had a learning disability. And there seemed to be tensions because professionals were trying to find some support that would work well for them. But support is very often organised in those boxes. So there is a personality disorder service, but that service won't work with people who have a learning disability, even if they also have a personality disorder. And perhaps it's that personality disorder that is causing them the difficulties that they need support with. But because they have a learning disability, they can't access it. And so this is also a reason for delay.
Equally, there were some situations where it felt as if staff were scattergunning, where because they weren't quite sure who would accept the person, they might refer through to 10 or 15 different places, hoping that one of those referrals would stick. Now each of those took some time before the agency made a decision. It might be a no, in which case the process had to start again. So please don't put us in boxes, but please don't scattergun across multiple different options at once, people told us.
Tip 7. Give me the chance to try life outside.
Lots of people we spoke to felt that they had to prove that they were able to come out of hospital, but often they weren't given the chance to prove that they were okay to come out. Sometimes that could create a catch-22 situation as well, where the person felt they were stuck because it was physically impossible to actually demonstrate to people's satisfaction that they're okay.
In a hospital environment, it's very different to living in the community, and so it's very difficult to assess how someone will respond to community life when you're in an entirely different environment in the hospital. And so there's the message here is around giving people the opportunity to try living in the community and to through that process to learn about what support they do and don't have in that environment.
So I met with one woman who felt she was really stuck because what she needed to move on was unescorted leave in the community. She had grounds leave, she could wander around the grounds, but she was turned down consistently for unescorted leave. And she said that the reasons given were that she might assault somebody, a member of the public. As she pointed out to me, there were people wandering around the grounds with her, other people, staff, other people who lived at the hospital, other patients. She'd never assaulted one of them, but how could she prove that she wasn't going to do it unless she was given that chance?
Tip 8. Please help me with the trauma I've experienced.
Many of the people who took part in our research had experienced really significant trauma at different stages in their lives, as children or as adults or both. That was certainly our impression from people's case files, and they talked to us as well about how traumatic it can be being locked up in long stay settings for significant periods of time, also alongside other people who might be really unwell at different periods. Our sense was that trauma was a key factor for people, and we wondered, and staff wondered, whether there was enough individual psychological support to help people deal with that trauma, and whether, beyond the role of individual psychologists, all staff working in these situations should be trauma-informed in terms of their practice. Otherwise, it was difficult to see how people could overcome some of what had happened to them in their past.
We met people in the study who had experienced a lot of trauma. Some of them, it was trauma they'd experienced before they went into hospital, trauma in their childhood or adolescence. And for others, it was trauma they'd experienced through being in hospital. Hospitals are not nice places to live. There are some fantastic staff who work in them and, pockets of really, really good practice. But they are not nice places to live, and things happen in hospital.
The hospital journey that I had exacerbated my trauma. So I came in with trauma in terms of my parents didn't understand my self-harm, being autistic. And so I came in with that trauma, but then I stayed in hospital for the trauma that happened in hospital, the systemic trauma around the restraints that I'd be in for kind of 1.5 hours at a time, the injections with medication. When they used to restrain me, it'd be like a lot of floor restraints. And so it really was traumatic.
Tip 9. Don't let us fall through the cracks.
This research found all kinds of fragmentation and divisions between different parts of our health and social services, between mental health and learning disability, between children's and adults, between people in different parts of the country as folk moved around from area to area, between health and social care and forensics, between public and private, all kinds of different cracks and gaps that people could fall down if we weren't careful.
So sometimes it's arguments about who's going to fund something, and they are just stuck. They can't move on if people don't agree and don't have this common goal.
Often the elephant in the room is money, and that, I think, manifests itself in several ways, but probably one of the most visible and direct ways that it impacts on individuals is when it reaches the point of actually primarily health and social care, reaching an agreement about who will pay and how much each organisation will pay towards the cost of a person's support in the community, which may actually genuinely be a huge amount of money.
Being autistic and having psychosis, I feel like because I was shifted from unit to unit, I did fall through the cracks. And I think that if I had gone to my secure unit maybe a few years beforehand, maybe I wouldn't have needed the whole 4 years in hospital. Maybe I would have only needed like 1 or 2 years. So I feel like there wasn't much early prevention, there wasn't much early intervention. I wasn't given a voice or a choice. And maybe if I didn't fall through the cracks of going to all these different units, maybe the outcome would have been different.
Tip 10. Don't set us up to fail.
All of the study and all the people involved in the study really want people to move out of hospital, and they want them to do it as quickly as possible. However, there is a caveat, because what we don't want is people to leave hospital, for their support to fall down for whatever reason, and then they come back. So I met one person when I went back to see everyone a year later, and in that time, in that year, he had moved out of hospital, but he told me that he was there about 2 weeks and that it didn't work out and he had to come back to hospital. And he said that actually he would have rather waited a little bit longer and for that support to have been absolutely spot on and what he needed than to go out and then come back again. He just seemed diminished really from the first time I'd met him, and that was really, really sad. And so I think although we desperately want people to move out, and there is no excuse for kind of people not doing their job or laziness in the system, but it has to be right. It has to be right, because otherwise it's not going to work.
The research has highlighted the multifaceted difficulties faced by people with learning disabilities and/or autistic people in their journeys back to life outside of hospital. However, in the course of the study, positive experiences and outcomes were also shared by some participants and by members of the reference group, providing a view of what success looks like. Matthew, for example, now lives in his own flat, with a skilled team of support staff who help him to navigate situations he once found difficult. Matthew uses his love of cycling in his work as a courier, and in his spare time he can often be found flying or fixing his drone.
I've got a provisional driving licence, which I used as ID, and hired the voice scooters, and I'm hoping to learn to drive fit one day. And I also got a job doing Uber Eats work, doing deliveries for Uber Eats on an electric bike. And also, and the staff support me whenever I need it, like today, bringing me to Birmingham today to sort of work here. And also, if I struggle with something in my flat, they will come down. If I phone them, as long as they're free, they'll also have As long as someone's available, they'll come down to help me.
Mandy was a founding board member of the rights-based organisation Changing Our Lives, where she co-led several pieces of work locally and nationally. She now lives in her own flat with support. Mandy regularly competes in Special Olympics tournaments, especially in swimming, where she has attained several gold medals.
I like it in my own home better, because I can take my things with me if I want to. Like my DVDs, and I like to watch DVDs in the night time in my bedroom. I like the staff. We're having new staff now, new place, new staff.
Zizi is now studying neuroscience at university and leads a charity which aims to improve recovery outcomes for autistic children and young people in psychiatric services. She has spoken internationally in her role as an autistic youth mental health advocate. However, it was only after several years of repeated difficulties and frustrations that Zizi's discharge from the hospital system became a reality.
When I went into my secure unit, that's when they looked at me as a person, and they didn't just shift me to another unit when things were too much for them. So they got together and they said, what does your ideal placement look like? Where would it be? What area? What places would you like there to be nearby? Would you like shops there? Would you like a gym there? They just asked me loads of questions about what I wanted, and it wasn't about what they wanted, but it was about what I wanted and needed and my needs.
We've been asking ourselves as a research team, what would success look like? And in the long term, you'd want to see a situation in which people were leading ordinary lives in the community, lives of their choosing, in places of their choosing, with the kind of relationships that they want with family, friends, and their local neighbourhoods.
I don't think those things are too much to ask, really. It's nothing different to what you or I or the people watching this film would want in our lives. And I think if professionals start with the person at the centre and forget the labels and the diagnoses and the boxes and just look at what that person needs and wants in their life, then they build the support around that.